And then this is a transition slide to talk about uterine artery embolization. So now we're getting kind of towards the end. This is what a fibroid looks like. This is the fibroid that ate Fredericksburg. So this is normal uterus being stretched out just like it would be with a baby by this 5-centimeter fibroid, and there's another one there. And so indications for uterine artery embolization, fibroids and bulk symptoms. Okay, so what are bulk symptoms? Well, you can imagine if you're carrying around a fibroid that's the size of a baby or thereabouts, that will recreate a lot of problems that you have in pregnancy. I'm going to the bathroom all the time. I always feel pressure on my rectum. I'm constipated and it's difficult for me to evacuate my bowels. I have this, pelvic heaviness that I can't really explain. So that's bulk symptoms. Menorrhagia is sort of, that's when I talk to people, I say this is our target patient, is someone who's having heavy bleeding, because once those fibroids are taken care of or devascularized, they typically will not have, it's rare to have a patient who comes in with bleeding who's not better after her UAE. Pain, I sort of couch a little bit just because there are 24 reasons to have pain in your pelvis, of which fibroids is one. So, when patients come in complaining of pain, I say, you may get better. There's no way that we can guarantee that. Although recently we've had some pretty good success with women who have presented just with pain. And then adenomyosis is kind of a difficult thing to explain, but it's sort of endometriosis, but endometriosis of the uterine lining itself, and there's kind of a secondary indication for UAE. So how did we get started? Well, the radiologists have been putting catheters and stuff in patients ever since the 1960s, and people started embolizing things that weren't bleeding and weren't supposed to bleed a long time ago. So there was a French obstetrician gynecologist who had a friend who was an interventional radiologist, and he says, when I do hysterectomies or myomectomies on these patients with fibroids, they all bleed. Could you embolize those patients before I take them to the operating room, and I can work with less bleeding? And they said, sure, it sounds reasonable. Well, you can imagine that it doesn't take long for someone to get a cold or whatever and not be able to go in to have their hysterectomy or their myomectomy. And they found that these women, even without surgery, noted that their symptoms were much improved. And then, so sort of through the works of people like Dr. Spies up at Georgetown, SIR and interventional radiology in general has sort of made a lot of strides towards developing this procedure. And so everyone gets an arteriogram, and this is what an arteriogram looks like. So the catheter is up here, and we're injecting contrast, and this is the aorta, iliac arteries, and then you can see these arteries down here, these kind of corkscrew things, and those are the uterine arteries. So you fish around in there and find the uterine artery, and this is what it looks like. And this is, so-called tumor vascularity, where you see these sort of corkscrew appearance or hairpin appearance to all these vessels supplying a very large uterus. And so then we give them the embolic agent, and all of a sudden that goes down to wither on the vine. So everyone wants to know what we use, and I got these slides from this manufacturer's website. These are tris acryl, so basically cement beads. This is evil appearing PCA or PVA particles. It turns out that the technique is a little bit different, but they both work pretty effectively. Then they get admitted to the hospital with a PCA, for an overnight stay, and basically that's just to kind of get them over the hump. Something magical happens at bedtime, because the next morning, you go in and everyone feels much better. They get antibiotics. A lot of times, basically what we're doing is creating an internal Charlie horse, and so some of the battle that we fight is just nausea. But again, once they get over that, they do pretty well. Kick them out day number 1, follow up with the telephone call in the next couple of days, and see them back in 6 weeks. And then these are just some cases. So this is a patient I treated out in Seattle. She was 39 years old, had had iron deficiency anemia, and during her period had to wear Depends type undergarments because she was changing her pad basically continuously. And so this is what she looked like. This is her arteriogram. You can see the uterine arteries. This is what it looks like when you get in there. This is just like the burning bush appearance of big fibroid uterus. When we were done, so this was her pre-procedure MRI, and you can see this really big fibroid that's basically deforming her uterus. And afterwards, it's not gone away because we don't remove the fibroid, but given enough time, they just kind of wither out there. Another patient who had rectal pain because her fibroid was pushing back on her rectum and was getting up in the middle of the night. Again, here's her uterus, and you can see she has tons of, here's a fibroid posteriorly, and that's where the rectum runs. Again, another one, so the rectosigmoid colon, so she'd have problems. She also had a little fibroid inside of her endometrial cavity, so kind of pooching into it. We treat patients like this. It's important when we see them to sort of talk with them a little bit and say, this thing may just sort of pop off and you may pass it. And so actually most women, when you kind of prep them for that, they do a pretty good job with passing a little bit of fibroid material. Occasionally we have to get one of our gynecologic colleagues to dilate the cervix and just evacuate that. That's extremely rare, but it does happen. But this is what she looked like afterwards. So now that fibroid that was trapping her rectosigmoid colon between the sacrum is gone. This thing is gone. She didn't realize that she passed it, but she must have. But all these are much smaller. So complications, there are occasional. Basically, the complications are mostly the complications that you see from doing arteriography. Amenorrhea is sort of an interesting one. Given enough beads sort of to the pelvis, you can actually sort of stunt the ovaries to the point where they sort of give up trying anymore. Usually we see that in patients who are approaching menopause anyway, and most patients actually don't see that as a complication because they just want their menstrual flow to stop. Uterine necrosis and rupture is written about a lot by some of the gynecologists, although in practice it's just something that we don't really see. There's some case reports out there. And then there's always the question of, can I get pregnant after this? For years we said, you're not going to have any kids, after we sort of devascularize your uterus. There have been cases of patients who have ruptured their uterus during delivery, that kind of thing. But again, they're kind of rare, and actually now there are thousands of women, case reports and data coming out that say that you probably can safely become pregnant, but we don't recommend it for our patients. So UAE, well, versus myomectomy, what do you do? If you ask an interventional radiologist, he says, uterine artery embolization is great. If you ask a gynecologist, they say, myomectomy is great. And that's one of the first things that I tell patients is, a surgeon can go in and take out that fibroid. You can keep your uterus. Surgeon can go in and take out that uterus. It's never going to bother you again. The one thing that I can say is that I will not take out those fibroids. So they'll be devascularized, but you'll still have them and they can always grow back. The public says, whatever the new thing is, that's what I want. Especially if you can add the words laser or minimally invasive to it. But in reality, in 2008, ACOG, in their primary practice guidelines, listed uterine artery embolization as a primary therapy for the treatment of symptomatic fibroids. So, if you're comparing myomectomy and UAE, UAE has a very high technical success rate, and it has a very low complication rate. And the patients get out of the hospital and get back to work much faster than if you had an open operation, and that just makes sense. The problem is that like I said, I'm not taking out the fibroids, and so, you know, if you're continuing, you know, to have periods for 20 years afterwards, there's a chance that you may grow those fibroids back, but again, there's no reason that you can't have another UAE. As with everything that we do, patient selection is the key. It's important to explain to these patients exactly what they're going to have and exactly what they can expect, and that's kind of the story. Okay, so wrapping up. Venous disease, whether it's in the legs or in the pelvis, can be very painful and very debilitating. Fibroids can cause serious health problems. There are minimally invasive solutions to both, and if you have any questions, give us a call.